Reproductive pathology, the breast. All right, so for the breast pathology, this is very, very difficult material, but thankfully it's not as high yield as you think. All right, so the first thing we have to understand is overall the breast structure, specifically the glands. You have the stroma, which is the outside, and you'll never pick stroma as your answer. Okay, within the stroma, furthest away from the nipple, you have the terminal duct lobular unit. Okay, and this is where all carcinomas are going to arise from. So the TDLU is the site of most breast carcinomas. If you're going to put an answer for where the carcinoma started from, the answer is probably going to be terminal duct lobular unit, or TDLU. Okay, it will never be the stroma. All right, and then as you move forward towards the nipple, you have the lactiferous duct, and then that's when we reach the nipple at the end of the day. Okay, so let's start off with the benign breast diseases. The most important ones I'm going to start off with is inflammatory processes, okay? This is lactational mastitis. Lactational mastitis, it occurs during breastfeeding, and essentially you have dry skin near the nipple, which starts to crack because you're feeding your child so much. And so that dry skin starts to crack, and it leads to an increased risk of infection. And it can usually get infected by Staph aureus. Now, what happens is you treat the patient with antibiotics, but you tell them to continue to breastfeed. Continue breastfeeding is the most important aspect of the question that they might ask you for lactational mastitis, but relatively, it's lower yield. Next are the benign tumors. The benign tumors are something that they ask a lot about, but it should be relatively straightforward. Benign tumors are fibroadenoma and intraductal papilloma. Those are the two most important ones. You have to know them. Fibroadenoma is in females that are less than 35 years old, and it's most common there, right? And it's going to be small, well-defined mobile mass. Okay, that's how they will present it. And that might be the only thing they give you, okay? It's going to be composed of fibrous tissue and glands, hence the name fibroadenoma, and it does increase in size and tenderness with increased estrogen, okay? Next is intraductal papilloma. Intraductal papilloma is the only thing that we'll see serous or bloody nipple discharge. If you see serous or bloody nipple discharge, you're probably dealing with intraductal papilloma, okay? Very important. They will say it looks like epithelial cells lining fibrovascular core. Write that down, because that's very important. They talk about that. It's a small fibroepithelial tumor within lactiferous ducts. This is the only one that's within the lactiferous ducts. That's why we see bloody or nipple discharge, serous nipple discharge, okay? Now, that is the two most important things for benign breast diseases. You have to know those two. Lastly is gynecomastia. Gynecomastia is probably going to be present later on in other diseases, and we'll talk about that mostly for I would say medication usage, but you still have to know it. It's going to be breast enlargement in males, okay, due to an increase in estrogen, right? So if you have increase in estrogen in males, you're going to see breast enlargement, okay? Now, it's physiologic in newborns as well as at puberty in older males. And they love to ask you questions where a young kid, he comes in, he's like 12, 13 years old, he's starting puberty, and then he has this very tender portion of his area near the nipple. And it looks like a fatty, they'll say it's like a fatty area behind the nipple that's sensitive to the touch. What should we do for this patient? And it's going to do all these crazy intense things, or you could say, it's fine, it's physiologic, it's due to puberty, just let it go. And then as you grow up, it'll go away. That's your answer. Because patients that have it during puberty or newborn, it's physiologic. It will go away, okay? It may persist after puberty, but most of the time it will go away, all right? Other causes are going to be like hypogonadism, specifically in Klinefelter syndrome, you can see gynecomastia, as well as drugs. Spironolactone is one of the main drugs that can cause gynecomastia. So keep that in the back of your mind. Moving forward to breast cancer. So I know we always talk about breast cancer, right? It's the number one thing that is on everyone's mind. There's a breast cancer awareness month. I feel like everyone knows someone that has been affected by breast cancer, either a friend or a family member. And it's a disease that can take so many people's lives. So it's important to talk about it. But I will say it's not as high yield for the step 1 exam. So you don't have to worry too much about it. I'll focus in on the most important ones. And I will say it's relatively a good thing because it's harder to memorize it, okay? It's harder process. They don't really explain it too well within the book or anywhere, honestly, for the resources for step 1. And I think it's just because it's lower yield, even though it's so high yield in the real world and in clinical practice. So starting off with the breast cancer, it's commonly going to be seen postmenopausal, 70 to 80 years old women, okay? Now, what you have to know is that we look for mainly nipple retraction and skin dimpling. Okay, that's the first thing they're going to ask you about, nipple retraction and skin dimpling. That is one of the main signs of breast cancer. All right, and the overlying skin retraction signals that the suspensory ligament is involved, and that's what they'll love to ask. They'll say there's skin retraction or there's nipple retraction, skin dimpling. What's going on? What does that indicate? And it indicates that the suspensory ligament is involved. Okay, now another thing. There can be amplification or overexpression of estrogen, progesterone receptors, or HER2 receptors, okay? And so that will tell us if it's like HER2 positive, then we can attack HER2. If it's estrogen positive, we can give drugs that can attack estrogen. If it's progesterone positive, we can give drugs that antagonize progesterone. Exactly, you know what I mean? So that tells me that a triple negative, if it's ER negative, PR negative, and HER2 negative, meaning estrogen receptor negative, progesterone receptor negative, and HER2 negative, that means there's no receptors that we can specifically target. So that's why it's the most aggressive form if they're all negative. All right, the risk factors in females is obviously going to be increase in age and as well as family history. So patients that have the BRCA1 and BRCA2 gene mutations, they have an increased risk of breast cancer, right? But it causes, it doesn't mean you will get breast cancer, but it can potentiate cancer later on, okay? But it's not 100% accurate. Increased estrogen exposure also leads to increased risk of breast cancer as well as obesity, okay? Lastly, before we get into the specific types of breast cancer, you have to always check the axillary lymph nodes because the axillary lymph nodes is the main and most important prognostic factor for where the metastases will occur for breast cancer, for early stage diseases and diagnoses, all right? So moving on, non-invasive carcinomas. The one they care most about is going to be Paget's disease for these. Paget's disease is going to show and present with an eczematous rash with like a plaque over the nipple or areola. And that is going to indicate adenocarcinoma, okay? Potential adenocarcinoma because the Paget cells are going to have clear cells with halos, okay? They can also call them halo cells, all right? That's all you have to know. It's going to be eczematous or patch or rash over the nipple or areola. And the Paget cells are going to be essentially intraepithelial adenocarcinoma cells. So you have to know that it's an adenocarcinoma. Moving forward to the invasive carcinomas, what they want you to know about the invasive carcinomas is specifically the inflammatory invasive carcinoma. This is really important because the patient's going to present with breast pain with warm, swollen, erythematous skin around exaggerated hair follicles. So you're going to see like these dimpling, and they call it pois d'orange, which is just peel of an orange, okay? And you have to differentiate that from Paget's disease. Paget's disease, take a look at the photo. It's going to be an eczematous rash over the nipple, whereas inflammatory, you're going to see pois d'orange. So it's going to look like the skin of or the peel of an orange that has swollen erythematous skin around it, around the hair follicles, not around the nipple and areola. Okay. You can also see in the photo that there is nipple retraction, okay, secondary to the breast cancer. And the reason behind this is because we have obstruction of lymphatic drainage. The obstruction of the lymphatic drainage with inflammatory invasive carcinoma is what causes the pois d'orange presentation. Overall, that's it for breast cancer and breast pathologies. This was one of the hardest chapters or pages that I had when I was going through this. Just keep in mind everything that I told you. Don't worry too much about all the other information. They like to kind of confuse you with it. Definitely read up on it, but I'd say it's relatively lower yield for the things I did not mention.